Hey everyone, this is Mrs. Lewis, and I'm one of the level 4 instructors, and I'm going to talk to you about chronic kidney disease today. This is part of your threats to elimination. I do teach with doceri, so a lot of your slides will be blank. You will have to fill them in. Research shows that if you write stuff down, that you will retain it. So make sure you're writing stuff down, and if you're part of a study group, that's awesome. But study groups also help you succeed because you're teaching it back to each other, and teaching will help you learn the material as well. So let's talk about chronic kidney disease. What is it exactly? Well, it's basically defined as a presence of kidney damage, and that is with a GFR less than 60 over 3 months or longer. And that's established by the National Kidney Foundation. They kind of just establish these parameters. And what's unfortunate is 70% of people are even unaware that they have it, because remember we talked about how amazing the kidneys are. They're highly adaptive, and the disease is often not recognized until there's been considerable loss of nephrons because you have so many. But before you know it, there's damage, and I've seen some people not even know they had it until their GFR was down into the 30s or 40s. So it's unfortunate, but that's the reality. Half the cases are diabetics, and about a fourth are hypertension or your cardiovascular disease. So as you know, that the kidneys are very vascular, and it kind of makes sense that diabetes and hypertension go hand in hand with this. Let's talk about the stages. Again, I said it's chronic, right? So it is progressive. So you're going to see some staging as it progresses and gets worse. So as you know, if it's greater than 60 or 90, then they're basically going to talk about risk reduction with you. Now, there is a formula, this is a good to know, that gives you the GFR, but that is not something you have to know. It's a good to know. If you work in renal specialized, you probably will know more, but that is where they get these numbers. Now, as you can see, as it gets on down to 30, there's more aggressive treatment. They might see some signs and symptoms, and then less than 15, they're thinking about renal replacement. Renal replacement is just dialysis or transplant. They've got some uremia present, or they have to desire treatment, because there are some people that decide not to do it and they just go on hospice. So that is a possibility too, if they're completely, coherent and can make that decision. So just know that it is a staging disease, and that as it gets worse, the GFR drops, you will see more signs and symptoms, and there will be more aggressive treatment. And as it gets 15 or below, then they're going to need dialysis. As you can see here, 15 to 60, I like this visual because the 15 to 60 is gold, so it's or yellow, so caution, right? This is we gotta take care of the kidneys and conserve the kidneys so that they can stay in the yellow. As it gets red, 15 or less, remember that is when they're going to need to go on dialysis, or talk about going on dialysis, depending on if they're having some problems with urinary retention and uremic buildup, which most are when their GFR gets around 15 or less. ESKD is just end-stage kidney disease or end-stage renal. ESRD, you may see this term, and I wanted to make sure you are aware that does mean end stages, near the end. Not necessarily 15 or below, but somewhere around in there. The kidneys are just not functioning properly, so you're getting an end stage. They're getting into that end stage. And then what are you going to see? Well, they vary. Your manifestations vary depending on the cause of CKD, the age, the degree of compliance, the amount of urine output. So all of this, it varies, because you got to think, what about your diabetic? It may look different than your hypertension patient, or someone that had acute kidney injury that went into chronic, that's going to be a different, it's going to be very different. So your manifestations vary depending on the cause. And then what are the manifestations? Well, they're the result of retained substances. Often as the GFR goes down, your BUN and creatinine goes up. You're going to see some fluid retention and some signs and symptoms of uremia, which we'll cover in the next slides. Sometimes you'll see polyuria as they start to lose their ability to concentrate the urine. They'll say, oh, I'm just peeing a lot. I'm peeing a lot at night, or I'm peeing a lot. That's the kidney's ability to concentrate, losing that ability to concentrate the urine. And then metabolic, often diabetics require less insulin, which makes sense because the kidneys have to clear that insulin. So you can see some hyperinsulinemia. And then as part of that hyperinsulinemia, that stimulates increase in triglycerides, which causes an altered lipid metabolism. So there you have it, even more further risk of cardiovascular disease, or making it worse actually. So you're going to see some hyperlipidemia as well, just due to this. Electrolyte acid imbalance, sodium could be high, could be low, could be normal. Your hypertension, edema, CHF, you have to take all that into account and apply it if needed. Your calcium and phosphorus alterations, magnesium alterations. You want to stay away from magnesium meds, such as milk of mag, because again, the kidneys are not able to clear it. You don't want that magnesium floating around, or extra magnesium. Potassium, hyperkalemia is a problem, right? If they're retaining potassium, they're not able to pee it out or get rid of it, then we could see some hyperkalemia. Your metabolic acidosis is the inability to excrete acid load. So you could see Kussmaul's respirations as the body tries to compensate, but often, because of defective absorption and regeneration of bicarb, because remember the kidneys not only excrete the bicarb, but they will also reabsorb it if needed. Here's your clinical manifestation chart, and this is pretty sad. I mean, it looks like, almost every organ can be affected by kidney disease. And again, you got to think, some things are more applicable than others. This is not just uremia, it's uremia plus different problems with chronic kidney disease, such as, they're going to get the anemia due to the erythropoietin stimulates the red blood cell production in the bone marrow. You're going to see the paresthesias because of the uremia. You could see the pruritus and the uremic frost on the skin. So all of these things, even like seizures because of the encephalopathy with the buildup of ammonia, right? So all of these things can cause some clinical manifestations of CKD. Hematologic changes, again, due to the decreased production of erythropoietin, you're going to see some anemia, and most patients just kind of live in an anemic state because they don't want the hemoglobin too high, and we'll talk about that. But bleeding tendencies is a problem, impaired platelet aggregation, increased risk for infection due to the change in the white blood cell function, and a diminished inflammatory response. All of these hematologic changes could occur with your chronic kidney disease. All right, let's talk a little bit about the mechanisms of this bone mineral density problem. So we've got a decrease in our GFR. So because of that, we're going to have a decrease in our phosphorus excretion. And as the kidney function deteriorates, you got less vitamin D, which is converted to its active form, resulting in decreased serum levels. Remember, activated vitamin D is necessary to absorb that calcium from the gut, right? So the low levels of vitamin D results in a decreased serum calcium. So you got a decreased serum calcium, but due to that, the parathyroid hormone is, that's where it's tightly regulated. Serum calcium are tightly regulated. And the regulator is your parathyroid hormone. When hypocalcemia occurs, the parathyroid gland secretes PTH, which stimulates bone demineralization. It's basically like, give me that calcium out of the bones, because it perceives a low calcium. So it gets the bones out of the calcium out of the bones as well. Well, what follows but phosphorus as well. So we've got bone demineralization, increased serum calcium, increased serum phosphorus, and it's out of the bones. It's not in the bones where it belongs. You're going to see fractures. You could see some fibrosa. You could see some vascular and soft tissue calcifications, which calcium vascular calcifications is going to further lead to your cardiovascular problems. Let's talk about some diagnostic studies. History and physical, of course. We've got to do that. We've got to figure out what's going on, what brought this on, or, what is there a family history of this. And then dipstick urine, we want to look for protein, white blood cells. Then your albumin to creatinine ratio might be done. That's just an inflammation marker that there's a kidney spilling that protein. And, that might help with some muscle weight. Tell us about muscle wasting. So GFR is our best test. It's just a blood draw, right, that they're going to look at. Renal ultrasound, which is non-invasive, a good one as well. Your CT, possibly, but remember it's nephrotoxic, the dye is. And then your renal biopsy will sometimes be necessary to provide a definitive diagnosis. Let's talk about collaborative care. Our goals, we want to preserve that existing kidney function. Part of the art of nursing is being able to motivate your client, to help them buy into their healthcare plan, healthcare, their own healthcare. Empower them. That is the art of nursing. So we want to preserve that existing kidney function. We want to prevent complications, provide comfort. So that conservative therapy, conserve, health promotion, nutritional therapy, all of these things. Low potassium diet, depending if their GFR is dropping, we might need to watch it, right? If they're retaining. Low sodium for sure. Erythropoietin therapy, and a lot of times with erythropoietin, they will need iron as well. And then your calcium supplementation, which will also bind with that phosphorus in the gut. And then let's talk about drugs since we are there. Hyperkalemia. We're going to do what we know to do. Our sodium polycystyrene sulfonate, right? Or KXLate. Or that will get rid of it, right? That and dialysis. But these are chronic, so they're not going to rush them to the hospital to dialyze. They might, but it's rare because they're chronic. Your polycystyrene sulfonate or your KXLate or your IV insulin. Your IV insulin, remember, is temporary. It just kind of shifts that potassium. You usually have to give glucose with it. And then your IV glucose, your IV calcium gluconate to decrease those dysrhythmias, right? The risk of dysrhythmias. In your hypertensive drugs, remember your ACE and ARBs. A lot of times your ACE, as kidneys fail, they'll switch them to ARBs. Diabetics sometimes will be on ARBs. But hypertensive therapy or hypertensive drugs is important for our conservation therapy. And then the CKD MBD problem, our bone mineral density problem. We're going to do those phosphate binders. There's a whole list. You've got a whole list in your book. These are just a couple. Calcium acetate, calcium carbonate. So that'll give you the phosphorus. They have to take it with meals. It binds with the bowel, in the bowel with your phosphorus, and they're excreted. The side effect is constipation, but it is given with meals. And they usually, once they're at end stage, they're on about 1 gram a day. And they have to watch out for dairy as well. They have to watch what their dairy intake is, because that's got phosphorus in it. Then your vitamin D supplement or your calcitriol. Your epoetin alpha or your darbepoetin, those are your erythropoietin therapy. Often your side effects are hypertension or low iron, so they'll check the ferritin. If it's less than 100, they'll usually put them on some iron. If they try to keep the hemoglobin around 12 or less, a lot of people run less. They don't want it above 12 because that can lead to cardiovascular events, and we don't want that. So you'll just see a lot of times your CKD patients will run kind of low, even though they're on the Epigen or the epoetin alpha. Statins, don't forget about those. We're trying to decrease our cardiovascular risk, and we want to lower that LDL, lower those triglycerides. And then if myopathy develops with a statin, they'll try the atorvastatin, which decreases that risk. And then if their triglycerides are still high, they might try some fibric acid derivatives, which will decrease the triglycerides. This is your nutritional therapy. Again, there's a chart in your book, but you see it's individualized. But again, you got to think, where are they at in their stage of kidney failure? Do we need to restrict potassium? We need to know those high potassium foods such as, avocados, cantaloupes, baked potatoes, bananas, those type of foods. They don't need to eat a lot of those. Orange juice, all of that. So they will see a nutritionist, and they will get frequent lab draws to monitor this. Protein, again, we're monitoring albumin, we're preventing malnutrition. We want them to take protein, but we don't want them to take too much because, remember, the byproduct of protein is nitrogenous waste. So, which can lead to increased ammonia levels. So, especially if the kidneys are not clear and all that. So there's a fine line there. There's research that shows you don't want to decrease too much protein because of the muscle wasting. So sometimes they'll be on those special shakes and things like that. Phosphorus restriction, remember dairy, they're usually on about 1 gram of phosphorus, about 1 gram per day once they're on dialysis. And also know, like with peritoneal, they can have a little bit more protein. With dialysis, they don't. With kidney failure, they don't. It's still individualized, but it's a little more potassium. If their potassium is usually not as restricted with peritoneal, but it is with regular hemodialysis, and it is sometimes with chronic, depending on how much they're retaining. So all of that needs to be taken into account too. Water restriction really depends on the intake, right? It depends on how much are they holding on to water? Are they retaining water? Are they still putting out a good bit are they voiding a lot still? But it depends on, intake depends on urine output. So you got to do your same formula we talked about before. You got to consider the insensible losses, which is about 600. So 24-hour output plus 600 is what they can have the next day. And then let's talk about our nursing management. We got to get in there. We got to talk about family history, our culture, our habits, our mindsets, comorbidities, those type of things, current and past prescription drugs, over-the-counter drugs, those type of things, because we don't know what they're taking at home, and if that could be further damaging their kidneys. Because remember, we're trying to conserve and prevent, health promote. So motivation is vital. Again, using that art of nursing so that we can empower our patient or our client. Drug and diet compliance is very important. Again, we got to get them motivated. Avoid NSAIDs, decongestants such as pseudoephedrine and your antihistamines, phenylephrine will, both of those constrict vessels, and a lot of times people with hypertension already know that, but some people don't. So it's good, to make sure we know that, we teach that. And then your aluminum and your magnesium-based laxatives and antacids, they have to avoid those because you don't want that extra floating around, the magnesium and all. And then your nephrotoxic drugs, again, like NSAIDs and other drugs, they need to be aware of that are nephrotoxic. And then your herbal preps would need to be, looked at and approved by the doctor Beware of possible toxicities. You got to think about DIG and other drugs that are cleared by the urine, by the kidney, that may not be. So you make sure that you're aware and the patient's aware that they need to be aware of possible toxicity and what to look for. Remember, they need regular checkups, strict adherence. I can't stress that enough. As far as being at home, they need to learn how to daily weigh, because as their kidneys, if they start retaining water and their kidneys start to fail more, then they're going to see some increase in weight. So the daily weights is really important, especially too as they go on dialysis. Those type, to make sure to see what they're retaining. And then their blood pressure, they need to check their blood pressures. They need to know signs and symptoms of fluid overload, signs and symptoms of increased potassium. And then when this conservative therapy is no longer effective, then they will go on hemodialysis, peritoneal, or they'll need a transplant. So that will be when? What would their GFR be? 15 or less than 15. 15. And, it really depends on the doctor. But your book says 15, or less than 15. Family needs clear expectations and support. They need to buy into this too, especially if, say the significant other does a grocery shopping or whatever. I mean, they're going to need to have some teaching and nutrition counseling as well, so that they can be supportive. And they might even need a support group to go to, because this is huge. This is a huge change, a life change. Can be life changing. Now, how will we know if what we did was working? Did all of our efforts pay off? Well, were there fluid and electrolytes? Their fluid and electrolytes will be within normal limits. They will be an acceptable weight. They won't have a bunch of weight loss and be emaciated, have muscle wasting, right? So less than 10% weight loss. And then their comorbidities will be controlled. That is something that, again, if we can get them on board and empower them to control, to control their diabetes and control their hypertension and cardiovascular disease, that is the goal. Okay, I think that is all. Yep. So I hope that you have a wonderful rest of the day, and I will see you soon. If by chance you have any questions for me, remember you can look me up, Mary Lewis. Look me up in the staff directory. Reach out to me. I'm not perfect. I could have made a mistake. Please reach out to me, and so that I can fix this and explain anything you need. I am available to you. So I will see you soon.